Um, so I mean, I'm gonna skip over the good stuff, but I'll go back to it later on. Why did you end up doing a Master's of Health Professions Education later on after your MD and your residency?
So I started it in my residency,
Mm,
and I did the master's after, because I had to finish it. I started in PGY4 in
yeah,
emergency medicine. There's a basic fellowship year. It's now in PGY5,
yeah,
which would have been easier, but it used to be in PGY4, and then we would halt everything and go on sabbatical for a year to just learn emergency
the
medicine really well,
restructure.
conquer the exam, and then continue. And what it actually ended up being was that um, I'd always wanted to do more education work, and I realized that in at least the medical setting, and probably across healthcare, the standard is not. There's no bachelor's of educations for doing health professions education and medical education, and so that's just not. That doesn't exist because most people have a professional degree. So would they go back to do a bachelor's? Probably not. And so I think it's probably a branding thing. And so master's education is kind of was the industry standard at the time when I was doing my medical school work, and I had volunteered on a lot of committees, and I came across a mentor who said, "Hey, you should probably consider doing a master's at some point." I'm like, "Okay, cool. Well, what do I get out of it?" They're like, "Well, I think to do the kind of work that you're doing right now as a learner, because I was volunteering for all these committees and doing curricular design and things like that, you might need the degree to get in the door when you're junior." And so um, that was one piece of advice. The other part of it is that if I wanted to go on to do research work, I didn't have the training to do research. I was interested in doing research, but I actually didn't know how to do any research.
Hmm.
So that was the other impetus, was that I wanted to find a master's program that would allow me to learn research methods in health professions education.
That's fascinating. Okay, two questions there then. Number one, what was the main difference between what you learned during that master's and your bachelor's degree?
Yeah,
Yeah, let's ask
they're
that
completely
first.
different. Completely
Yeah.
different. So in a bachelor's degree, it's about the application of theory. It's about really just reading textbooks about how to teach the understanding of psychology
Hmm.
and the basic science. It's kind of like applied version of Psych 101.
Okay.
And then it's about those immersive experiential things, where you would actually um, take the things that you learned in class and apply them then in the real life setting. And that's basically it. It's classroom, practicum, and it's done. There are some longer programs now that are more of a master's, and that would have some level of program evaluation or some kind of research scholarly project.
Hmm.
And I think my alma mater, Boise U of T, actually only has a master's now. They don't have a bachelor's of education anymore,
Interesting.
because they evolved their program to be more inclusive and of those higher skills.
Yeah.
In my master's, it was more theoretical, just with most masters. There was no requirement for practicum. The the re- the um, the expectation was that if you wanted to teach, you would just be doing that as your real job, and that you might use your classroom learnings to power your work in the real life setting,
Yeah.
but you also might bring your real life work into your master's classes. So it's more like an MBA, right? So an MBA usually doesn't have intercalated work experiences. They expect you to come with work experience and then use the MBA to digest and reflect and then apply what you've learned retrospectively to the experiences that you've had. And so it's more in that kind of professionals school vein. At my master's, we also had a mandatory thesis component,
Hmm.
and so I had to set up and then complete a research project,
Okay. All right. So one.
which would not have been a requirement. Sorry, which was not at all a requirement of our bachelor's program.
Hmm. Hmm. So you also mentioned in your previous spiel that you needed a master's of professional education, at least a master's level degree in education, in order to sit on the committees and to do the work that you were doing. Why is that? Is that just something that's expected in like medical administration and education? Is it like cultural context?
I think there's some culture. I think
Mm,
the expertise is important too, right?
yeah.
And so the master signifies that you've done advanced training, that you've got actual credentials and chops and has gone through experience, that gives you a perspective on and a facility really
Mhm.
with the literature that you've actually delved deep and you've learned to apply all these concepts
Mhm.
um, in a scholarly way, right?
Mhm.
That's why I think in a lot of places, in order to get a faculty position, increasingly there's a requirement for some level of advanced training beyond your residency
Mhm.
and your MD.
Mhm. Hmm. Okay, I'll file that away so that I'm able to keep that in mind when I go on to do my postgraduate education. But
Mhm.
we'll go back to, I guess, the specialty that you went into. You went through med school. Um, I guess, did you have any experiences during med school which you found shaped your path to where you are now?
I think that I was interested in emergency medicine because I like the pace.
Yeah.
I realized that I'm at my best when I have a lot of things being thrown at me. I have the capabilities of being able to juggle multiple tasks and switch between them,
Hmm.
not seamlessly, but not as interrupted as others.
Yeah.
Um, I made a joke the other day at a presentation that, you know, attention deficit is not a disorder if it's what you're supposed to do, right? And so if you're supposed to do
That's
rapid
fair.
task switching constantly, it is a problem if you're trying to get a 5-year-old to like stay put in the
Yeah.
classroom. But it's not a problem if I'm supposed to constantly pay attention to the whole situation, juggle between 16 patients, and be able to immediately flip over when the charge nurse walks up to me and says, "We have an incoming VSA arrest and they're arriving in 5 minutes."
Yeah.
I need to be able to park everything I was thinking, drop off the things I needed to do, immediately triage that, and then go and get ready for someone who has no pulse to be received in the trauma bay or the recess bay, right? And
Oh.
so that is something that I know that I discovered about myself, and understanding that I am very good in crisis situations where I'm balancing multiple things allowed me to see that that was literally what I would do every day within the emergency department.
Mhm.
Maybe not that exact scenario. It's a little calmer than that most of the time. But there are times when there's 5 very acute patients that are coming in and you're bouncing from your room to room and then you have to recalibrate and take care of the other patients that were on the go.
Honestly, I've seen that because I did a few electives in Emerge, and it's always like amazing how docs can just bounce back and forth and handle so many different situations that are escalating at a time. It's kind of like artwork to some extent because there's so much that has to go into to coordinate it well, but there's so much knowledge and experience behind that. But
Mhm.
to move on to, I guess, your work in, I guess, with Canadian, what is that? And
Actually, can I just interrupt this? The natural segue here will be ask me about my thesis work
okay,
because it's about prioritization. So say that question again and then edit this part out.
will do. So tell me about your thesis work.
Yeah, so the thesis work that I did was actually to examine what I've just been describing,
Okay.
how we learn to navigate multi-patient environments. And so that's what I did for my master's thesis was that I sat at a computer one day in my 5th year residency. I had been thinking about doing a whole bunch of different topics, but I had this moment where I was running the whole department. My attending had gone to get a coffee or something, I think, for both of us. And I had 2 learners that I was taking, charge of, and they were reviewing with me. And when my attendant came back, coffee in hand, handed to me and said, "Okay, let's run the list." I went through the entire list of 16 patients. I knew which house staff was supposed to do what. I knew which things had to be done for what patient. I knew exactly what was going on at all times. And I was like, oh my goodness, how did this happen? Because the PGY1 sitting next to me could barely handle explaining the one patient that they had. And I had to support them in it. And I was like, how did I get from being like that person to being the person I am now? And that moment of realization was the moment I said, there's a skill set here that we teach and or learn, and it's not well articulated. Because it wasn't something that, as a senior resident, I was intuitively taught by attendings or had an algorithmic, sorry, it was something that I intuitively was taught through my training, but it wasn't something that an attending ever pulled me aside and said, "This is how you do this, and these are steps you follow." And so I was like, "That's probably an area ripe for discussion." Then. And so, um, I fell into this chasm um, of unknown territory. And so then you have to build your way back out. And so as a researcher, that spurred me to put a grant in and actually formulated a plan for a study proposal. And then we embarked on actually a program of research around how people teach and learn in multi-patient environments and how we engage in that task prioritization and other things that came out of the literature.